Okay, so spondyloslisthesis is a condition that primarily affects females over the age of 40 to 50 years old. And that's degenerative spondyloslisthesis. There are other types, such as traumatic, which primarily affects athletes. And this happens primarily in females, especially gymnasts. The other type that makes up a large portion of cases, about 20%, is the congenital spondyloslisthesis, which primarily affects pediatric females. Two outcome measures are validated, which are the Zurich Claudication Questionnaire and the Oswestry Disability Index. So how this happens is there's a defect at the pars interarticularis of the facets, and a defect or fracture, scotty fracture, can occur, which allows the anterior slippage of the vertebral body on the subjacent vertebrae. And this can be occurring from macro trauma over a long period of time, or macro trauma, or as just a congenital deformity, as I mentioned before. Extension and rotation will likely aggravate the symptoms that the patient is experiencing. Being in a prolonged position, such as sitting, standing, anything that requires them in a static position for a while. But it can be relieved, luckily, by flexion-based activities and just changing positions, leaning forward, anything that allows them to kind of get some movement going. Walking will also typically cause pain that's distances usually greater than 250 meters. It's better in the mornings, and then it can be worse in the afternoon depending on how much activity the patient has done throughout the day. Precautions to keep in mind include if the patient experiences their symptoms more in prone or with walking, then that's typically going to be something you might want to avoid in the acute stage or depending on the stability. Manipulation isn't necessarily contraindicated for these patients, however, there's not very much research on the effectiveness of it, but it's up to the clinician to make that decision. And then, of course, the modalities will all have their own precautions and contraindications as well. So active movement testing will likely reveal that flexion is normal, but when they come out of flexion, there's some sort of hitching or catching or pain that they feel when they're extending back to neutral. Extension will likely be limited and painful. Same thing with side bending and then rotation as well. H&I testing will all be painful in all four directions just due to the nature of the side bending component, especially into extension. And then quadrant testing will likely reveal the same, and this might not be due to the hypomobility, but just because of the side bending component that each of these provide. Passive overpressures will likely be painful in these positions, especially if they already are experiencing the pain. PIVMs will reveal that there might not be pain on the flexion during the intervertebral motion. However, returning to the extension can sometimes cause their pain. Side bending will also be painful as well as limited. Not much manual muscle testing will be performed. There's not really much of a formal assessment, but however, assessing for TA and multifidi core activation can help you guide your treatment, as a lot of times this is lacking in these patients. They're typically hypomobile due to muscle guarding around the affected segments, and then especially above and below, which can sometimes lead you into maybe sort of the mechanism of the injury. They might be hypermobile at the segment if we're able to relieve some of that muscle guarding, but you might be hypermobile at the segment that is affected and maybe even one or two above and below it. When palpating, you'll likely find that the erector spinae have increased tone, as well as the hamstrings, as they sort of act to compensate for this deformity. And then there might be trigger points in those muscles as well. Special tests that can be used include the double straight leg raise test, which can, when positive, is high specificity and sensitivity for this condition, and then straight leg raise can be used to differentially diagnose a disc herniation or other pathology. The palpable step-off test is when you're just feeling the spinous processes, and if there's a palpable step-off, that means that there's likely to be a spondylolisthesis, which can be graded based on the amount of slippage. So differentially diagnosing osteoarthritis of the hip or spine, vascular claudication can be ruled out with an integumentary screen. Tumor of the spine or surrounding area might provide referred pain to the area. Systemic infection, which hopefully can be ruled out with the systems review or the constitutional symptoms that the patient may present with. And then a disc herniation, which can hopefully be ruled out sometimes with the straight leg raise and cross straight leg raise tests. Imaging is done with a lateral radiograph to diagnose and grade the injury. And then oblique views will likely show the pars interarticularis defect, often the Scotty dog fracture, which is the fracture at the pars interarticularis. CT and MRI can show the soft tissue pathological involvement, especially the muscle and the nerves in the surrounding area. So some things that you need to look out for referral include symptoms of saddle paresthesia or anything consistent with cauda-equina syndrome. These require an immediate trip to the ER, as these are potentially life-threatening as they will continue to get worse. So progression of neurologic symptoms might also clue you in to refer out to a physician or to the emergency room. Claudication that is unrelieved by rest might also clue you into a referral. Surgical indicators, there's not really much, but progression of neurologic symptoms will likely guide you to surgery, which can be done via bone graft or instrumentation to fuse the vertebrae. Thanks.